Hello everyone, I'm going to be talking about a basic head CT search pattern in this presentation. So the first step of a search pattern should start with looking at the Scout radiograph. And I don't have a good picture of a Scout radiograph saved, but the things you can look for on it are going to be your cervical spine, look for fractures. Sometimes they can show up good on the Scout radiograph, as well as any foreign object or tubings to help you when you're reading the actual head CT portion. Now, most of the time will be spent looking at brain windows. If you look at brain windows a little bit more closely, you see that the brain windows are much sharper window widths compared to soft tissue. If you compare it to, soft tissue here, soft tissue window width is around 400, while the brain window width is about 80. That just allows a sharper delineation between the gray matter and the white matter, which are much closer in their Huntsfield unit attenuation compared to the remainder of the soft tissue structure. And by using these narrower windows, you allow that distinction to be better. Now, when I read the head CTs, I typically start with the posterior fossa just because I want to make sure I give it a good attention. Uh, to do that, you first start at the very craniocervical junction. So I'll go all the way to the bottom, make sure I'm all the way to the bottom, look at the cord and the CSF surrounding the cord. Stuff you're looking for are any blood that might be there, or any evidence that brain parenchyma or the cerebellar tonsils, in fact, have gone down. That could be a sign of tonsillar herniation, etc. Then when you come up, I start looking at the cerebella on either side. Now, in general, when you're looking at these head CTs, things you're looking for are masses or mass effect, blood, which could be in the epidural space, subdural space, subarachnoid space, or in the interaxial space, and any evidence of an infarct, so loss of gray-white matter junction differentiation. So as you're going, I'm go through the cerebellum one side at a time, look for any mass effect. If things that are supposed to be in the midline are shifted over, that's evidence of mass effect. Looking to make sure that these the cerebellum gray, you can see cerebellum also has gray-white junction differentiation, looking that that is preserved. Cerebellar infarcts tend to be these like little wedge-shaped hypodensities here, so keep your eye out for those and go one side at a time basically. While I'm here, I usually look at the fourth ventricle because sometimes the sign of a cerebellar mass or mass effect is actually effacement of the fourth ventricle. So you take a look there, make sure that it's symmetric left to right. Then you look at your brain stem, so your medulla, your pons, as well as your midbrain. Now, brain stem can be challenging because there's a lot of streak artifact. In general, posterior fossa can be challenging because of all the streak artifacts. So, for instance, like here, you can see the anterior aspect of the pons compared to the posterior here is more dark, but that's just because of streak artifact. You can see this nice line here, and all this dense bone here. You can see what thickness of bone right here has caused that streak artifact, has caused this area to be artifactually lower in attenuation. So keep an eye out on those. Sometimes when you see hypodensities in the brainstem or cerebellum, always look at them in multiple planes, and that would allow you sometimes to see these lines that are very characteristic of streak artifact. And then finally, while I'm looking at the posterior fossa, I look at the basilar cisterns, just make sure that they're not effaced, there's no blood there. While you're looking there, make sure to look at this retroclival region, because sometimes the retroclival hematoma could be your only sign of a bad craniocervical junction injury. Once I'm done looking at the posterior fossa, I then look at the supratentorial brain, and that includes the cerebral hemisphere and the cortex in the hemispheres, as well as the basal ganglia or the deep gray matter, here, basal ganglia and the thalami. Usually I start with the hemispheres, and again, things you're looking for are masses or mass effect, hemorrhage, and loss of gray-white matter junction differentiation. So it's nice sometimes to just start at the very top. A lot of times if there's like a mass on one side of the brain versus the other, you see all the sulci are sort of effaced. So I tend to go one hemisphere at a time, and sort of either depending on my how I feel that particular day, I either go very slowly and look at the entire hemisphere back to front, very slowly, or I go a little bit faster and sort of split the hemisphere into threes. Anterior section of the hemisphere, mainly the frontal lobe. Then when I'm going back down, I'll look at the middle portion of the hemisphere laterally, including the insula. Insula is pretty important, especially, you have the insular ribbon sign. It's one of the first areas that tends to lose gray-white junction differentiation when you have an infarct. And then finally, once I'm done with the middle part of the hemisphere, I go posteriorly to the occipital lobe and the parietal lobes. Now, things to look for, as we said, masses. So how could you tell there's a mass? You look at these sulci. I mean, if these sulci, they need to be symmetric from left to right. If you see the sulci on one side are nice and well defined, but you have no sulci on the other side, that's your clue that there's a mass somewhere. You look at your midline structures and your ventricles, and a lot of times if there's a mass or mass effect, the ventricles will start to look asymmetric, and sometimes the midline structures would shift. And in a lot of times we measure midline shift. To measure the midline, usually the superior sagittal sinus is a good indicator. So you go from here to here, that's your midline line, and then the septum pellucidum can be a good indicator of where the actual midline of the brain is. So then you measure where the septum pellucidum is with respect to the actual midline of the calvarium, and you have your sense of midline shift. Here, as you can see, if you go by midline of the calvarium and the septum pellucidum is right smack there, so there's no midline shift. As far as gray-white matter junction differentiation, again, these are nice sharper brain windows, so you look there and make sure that they're all preserved, including the medial gray matter. A lot of times you might forget to look at the medial gray matter right here, and if you just focus on the lateral hemispheres. And finally, always when you're scrolling on each hemisphere, stop by the basal ganglia and the thalami and make sure that the gray-white junction of these deep gray structures is also preserved. Basal ganglia, as a reminder, just consists of this caudate lobe as well as the lentiform nucleus, which itself consists of the putamen and globus pallidus. It's pretty hard to tell the difference between putamen and globus pallidus on head CT. That's why I like that lentiform nucleus term. And then aside from the basal ganglia are, of course, the thalami, and those are these medial structures. They're those sensory relay stations. And so just also a reminder, basal ganglia is different from thalamus. So thalamus is not technically part of the basal ganglia. While you're still in the axial plane, it's good to look at stroke windows. Now, stroke windows are actually a much sharper window even compared to the brain window. So the window widths in center are usually between 40 to 50. You should play with your own institutions uh, acquisitions to see what Windows settings work best. As you can see, what this thing does is it makes the white matter even darker and it brightens up the gray matter even more. So the gray-white junction differentiation really sort of gets highlighted here, and you can pick up subtle infarcts much better with this particular window setting. Using this stroke window is especially important, especially if you're reporting aspects. Now, if your institution requires you to report aspects, you report it. If it doesn't, I typically won't, just because aspects, it's pretty well known that it's quite subjective, but if the institution and your referring clinicians want it, you should do it, because a few of those large trials for endovascular therapy used aspects. So if your institution wants it, you should absolutely report it. Next, I look at the ventricles. So now when you look at the ventricle, you're looking for symmetry, any evidence of asymmetric effacement, particularly if you've identified a mass or something, or you've identified an infarct. Make sure that the adjacent ventricles look symmetric to the other side. And then look for any hemorrhage within the ventricles, particularly dependent portions of the ventricles, like here, the occipital horns right there and there. Obviously, layering blood, it tends to go there. Looking at the third ventricle, again, layering blood in the third ventricle would end up somewhere over here, and then layering blood in the fourth ventricle sometimes can get stuck like right around here or like around here. So make sure to look for those, look for symmetry, look for any evidence of effacement, and in particular, try to look at the aqueduct. Now, aqueduct is pretty thin, especially if you only have thick sections, so you can't rely too much on whether it's effaced or not. But if you have a big mass around here and these supratentorial ventricles look very large, then you probably have aqueductal effacement and stenosis. So last but not least, you want to look at your vessels, especially if you've got thin section images, which I've shown you here. So on your thin section images, for instance, you can see here the left vertebral artery, right vertebral artery. Now they're coming together and they form the basilar artery. So as you can see, you see these vessels pretty well, especially with the nice dark CSF surrounding them. And if there were to be an aneurysm or something, you would see the little outpouching even on these non-contrast CTs. So you follow out your basilar artery. Now it's splitting up, as you can see, into both posterior cerebral arteries, right there and right there. Same thing with the ICAs. Now the ICA, the cavernous portion, would be impossible to tell on non-con from the adjacent cavernous sinus. They're both filled with blood and will look the same on non-con. But here there is the left carotid terminus splitting up into the MCA. And then the ACA, it's a little bit better seen here on this other side here. As you saw, this is the carotid terminus. splitting up into the MCA, and that's the M1 segment right here, and then the ACA right here, that's the A1 segment. Obviously, you're looking for aneurysms here, and also in the setting of your strokes, you're looking for any hyperdensity of the vessel. If you have thick section, do make the exercise of trying to look for these vessels. It'll be very difficult, but at the very least, look for hyperdense vessel signs in your MCAs, because that would be important to clue in about an infarct. Once I'm done looking at the brain windows on the axials, I look at brain windows on the sagittals. It's especially important if you only have thick sections. You really want to look at all your different planes of reconstructions to increase your sensitivity. Some of the things that the sagittal brain windows are really good for would be your midline structures, including your sella. So as you can see the pituitary tissue here within the sella nicely. So if there was a pituitary adenoma or something that was large enough, you would see it as extra soft tissue right here. Uh, Looking at the basilar cisterns here on the sagittal, you can see the basilar cistern and anterior to the brainstem very nicely. And if there was like a big mass here or a mass here, you would see effacement of this basilar cistern. So I would look there. Look at your retroclival region here. Again, sometimes the only sign of a bad craniocervical junction injury can be a epidural hematoma right here. So obviously make sure that there's bone and then there's just normal CSF, nothing else. And then on the sagittal, the tentoria look pretty nice as well. You can see here, that's the tentorium right there. And that's, as you're going there, that's tentorium. So something like a subdural hematoma that's got a tentorial component tends to show up nicely on your sagittal images. Then you go to the coronals, and again, the tentoria tend to show up nicely on the coronals. In fact, it probably show up a little bit better just because you see both of them at the same time. And if you see one of them asymmetrically dense or asymmetrically thick compared to the other side, that will be a clue that there's a subdural hematoma. You see the falx very nicely as far as looking for subdurals, falcine subdural hematomas right here. And again, you get many looks at the falx, so you can see that there's no thickening, asymmetric density, etc. And then the gyrus recti. Gyrus recti are just this medial aspect of the frontal lobes. Pretty common site for traumatic hemorrhage, but when you're looking at these on axial, they're usually just one or two axial slices. But if you look at them on the coronal, they're on multiple slices. You substantially increase your sensitivity for catching hematomas in those gyrus recti. So I always try to look at the gyrus recti on the coronal reconstructions. Then I look at subdural windows. Now, subdural windows, if you look at the window settings here, that you basically want to increase your window width to about 200 and then move up your center a little bit higher to about 80. What this does is it makes the inner margin of the bone a little bit less dense, and as a result, very thin subdurals that are touching the bone get accentuated. This doesn't do really anything for falcine subdural detection or tentorial subdural detection. This is just for detecting subdural hematomas that abut the calvarium. So basically, when you're looking at these subdural windows, you're just looking at each side adjacent to the calvarium, making sure there's no additional density between it and the brain. And sort of, they can be very subtle, but these subdural windows will help you pick up those very subtle, small subdural hematomas. So once I'm done with looking at the brain window, I'll look at the soft tissue windows. And so things to look for in the soft tissue windows would be the scalp. So you're looking for any signs of scalp soft tissue, hematoma, scalp swelling, etc. You can just go quickly one side at a time and look for any hematomas, etc. Then you look at the orbits. So looking at the orbits, you have your globes, you have your interorbital structures, including your optic nerve. You can see the fat pretty nicely. Orbits tend to show up very nicely on your coronal reconstruction. So here, if you go through them, you can see very nicely on the coronal, your extraocular muscles, your intraconal space, and then your extraconal space. So you're looking for any hemorrhage within the orbits or any masses, etc. You have your lacrimal glands in the superolateral aspect of the orbits on either side. And again, if they were abnormal, you see some asymmetric swelling, etc. And then finally, when you're looking at soft tissue, just take one quick look at any of the upper neck structures you can see. Typically, you can see the parotid glands pretty nicely. So look for any parotid masses. You can see like your peripharyngeal spaces nicely. You can look for those. And then the nasopharynx, especially look at the nasopharynx if you see evidence of mastoid effusion, particularly on the next steps of your search pattern. Next, we'd be looking at your bone reconstructions. Look at bone reconstruction. First, you start with the orbital walls. Make sure they're intact, especially your lamina propria. Again, similar to the soft tissues, the bones of the orbits show up nicely again on the coronal. And look on the coronal for orbits is almost mandatory because you can see the lamina propria on either side and the orbital floors very well. And sometimes you can see them only on these coronal images. They can be very subtle on actual images. So you're looking for those, any fracture or any abnormality in your orbital walls. Then you look at your paranasal sinuses, looking for any sort of soft tissue thickening, paranasal sinus mucosal thickening, etc. We'll probably have a lecture talking about how to read a sinonasal CT, so we'll talk more about like drainage and everything on that lecture. Then you look at your mastoids. Once you look at your paranasal sinuses, again, you're looking for any effusions. If you see an effusion in the mastoids on one side, always look at the nasopharynx on that side to see if there's a mass potentially blocking the eustachian tube. You'll then look at, when you're looking at your mastoid, always include the middle ear as part of your search pattern. So you can see here the middle ear and your ossicular chain right there. Make sure that if you see a mastoid effusion, make a comment about whether there's middle ear effusion as well. And then, of course, finally, you look at your cranium, so the rest of your calvarium. So I tend to, when I'm searching for the actual bones of the calvarium, I go anterior, so looking at like mainly the frontal bone. I go all the way down, ending with the nasal bones, looking for any nasal bone fractures that might be there. And then as I'm coming back up, I look at the posterior aspect of the calvarium, mainly occipital bone, coming back up. And then I go either side lateral. So lateral this way, I'm coming down, looking at those lateral bones, predominantly parietal and temporal bones, and then finishing up kind of here with the mastoid bone and the zygomatic arch, etc. I do the same thing on the other side. So I end looking at the bones by focusing on several sneaky areas that I find are pretty easy to miss stuff. Those include the cranial-cervical junction and C1. A lot of times on your head CTs, you actually do get the majority of C1, as you can see here. This particular CT, you get a lot more, but even on standard head CTs, you do get C1 a lot of times. So just make sure you're not dealing with unsuspected C1 fracture. Then I look at the craniocervical junction proper, and especially the occipital condyles, since that's almost always included. These are the occipital condyles. Make sure there's not an avulsion fracture. Those typically would be right around here. Where you get your avulsion fractures. I look at the occipital condyles on all three planes because they're pretty important. Make sure they're articulated nicely with C1, as you can see on this one. And then finally, also on coronals, I look at them. So for instance, here, this is what they should look like, as you can see right here. Again, nicely articulated with the lateral masses of C1. Looking at the other areas, I always want to take one good look at the zygoma. I feel like it's pretty, you see them often and pretty easy to miss something. And then the mandible and temporomandibular joints. Not all of the mandible is not going to be included, but a lot of the proximal portions of the mandible and especially the temporomandibular joint is going to be included. And so you want to make sure that this mandibular condyle is located in the glenoid fossa. It also shows up pretty nicely on the sagittal, so I always look on the sagittals for the mandible to make sure it's located and there's not dealing with some kind of an unsuspected fracture. I've caught a couple of unsuspected fractures. They typically tend to be sort of people who are drunk, and so they don't quite hurt quite as much to say, oh, my jaw, somebody hit me in my jaw and I hurt or something like that. And then finally, nasal bones. Now, again, when I'm looking at my frontal portions of the bones, I always try to look at the nasal bones, but I take one last look, and because it's pretty common to actually miss nasal bone fractures. So you look at your nasal bones right here. You typically see at least some of the nasal bones on your head CTs. All right, so that's about it for a basic head CT search pattern. The only advice I can give you guys as you're starting out is to just read as many head CTs as you can. It takes a long time to sort of get familiar with what normal is supposed to look like. And then the more you read, the more abnormalities you're going to see. And also, when you're just training, I mean, the more stuff you're going to miss. And those are actually pretty valuable, especially when you've got an attending that's going to catch all your misses. Misses can be very valuable in that, every time you miss something, just make sure to add it to your search pattern. And, you're going to have a pretty good search pattern. And when you're actually independent and on call, you're not going to make those same misses. All right. Well, thank you for your attention and take care.